Hello, in this video we'll be reviewing allergic rhinitis pharmacology. Allergic rhinitis can be summarized as any sneezing, itchy nose, eyes, or throat, watery eyes, rhinorrhea, runny nose, nasal congestion, and post-nasal drip. Non-pharmacological treatment include avoid exposure to the allergen, IgE tests or blood tests, nasal irrigation, neti pot, or boiled distilled H2O. Never use faucet water. For drug treatment, for chronic, moderate, and severe rhinitis, first line is going to be intranasal corticosteroids. For mild symptoms, you want to give oral antihistamines. Starting off with the first line of therapy, intranasal corticosteroids, we have beclomethasone, also known as Beconase or Qnazole, budesonide, also known as Rhino Aqua, fluticasone, also known as Flonase, mometasone, also known as Nasonex, and triamcinolone, also known as Nasacort. ADRs include headache, dry nose, bad taste, nosebleeds, and local infections. Black box warnings include adrenal suppression with long-term use, delayed wound healing, stunt growth in children, and an increase in intraocular pressure. So beware in patients with glaucoma. For counseling for Flonase and Nasacort, you want to shake bottle. For Flonase, you want to prime if it hasn't been used in 7 days. For Nasacort, you want to prime if it hasn't been used in 14 days. And when priming, you want to make sure to point away from you. And when putting it into your nose, you want to tilt your head forward and inhale while spraying into the nose. Some notes to take into account are these could be used for up to 1 week for relief. For pregnant patients, you want to use budesonide and you want to shake well before using. Moving on to first line for moderate symptoms, we have oral antihistamines. For first generation antihistamines, we have diphenhydramine, also known as Benadryl. Some things to take note with Benadryl is you don't want to use in patients under 6 years old. And for adults, you want to use 25 to 50 milligrams by mouth every 4 to 6 hours. Some ADRs to take note of are cognitive impairment and strong anticholinergic effects. You want to avoid in patients that are elderly, who have CVD, who may have prostate enlargement, glaucoma, asthma, excessive sedation, and avoid in patients less than 2. For any women lactating, you want to suggest a second generation antihistamine. And first generation antihistamines could cause photosensitivity. Moving on to oral antihistamines, second generations, we have cetirizine, also known as Zyrtec, levocetirizine, also known as Zysol, fexofenadine, also known as Allegra, loratadine, also known as Claritin, and desloratadine, also known as Clarinex. Some black box warnings to take note of are CNS depression, along with sedation when combined with other sedating medications. For levocetirizine, you want to avoid with patients with end-stage renal disease. For fixofenadine, you want to take with water. Avoid aluminum and magnesium products when taking antihistamines. And for pregnancy patients, you want to recommend either loratadine or cetirizine for best use. Moving on to intranasal antihistamines, we have azolastine, also known as Astelin Astepro, and olopatadine, also known as Patanase. Adverse reactions include bitter taste, headache, and nosebleeds, and these help with nasal congestion. For oral decongestants, these are products that contain D. This means they either contain phenylephrine or pseudoephedrine. We have phenylephrine HCl, which also known as Sudafed PE, and pseudoephedrine, also known as Sudafed, Nexafed, and Zevrex D. For these medications, they do stimulate the CNS system, so you don't want to take them late at night because they could cause insomnia. You want to avoid in patients less than 2 years old and separate with MAOIs by 14 days. Phenylephrine is contraindicated in patients with hypertension or tachycardia, and the onset for these medications are 15 to 60 minutes. For intranasal decongestions, we have oxymetallazone, also known as Afrin. These have adverse reactions of burning, sneezing, dryness, rebound congestion after 3 days. You want to avoid in patients less than 2 years old and avoid in patients using MAOIs. And these have a quick onset of 5 to 10 minutes. And you want to limit use to less than 3 days due to potential rebound congestion. And lastly, other products that could be used include intranasal cromolyn, ipratropium, montelukast, and sublingual immunotherapy. And that's all we have for allergic rhinitis pharmacology. Thank you so much. I'll see you in the next video.